My name is Bijan Teja. I'm an assistant professor of critical care medicine and anesthesia at the University of Toronto and a staff physician at St. Michael's Hospital. I think the unmet need, really, in my opinion, my PhD is focused on vascular access for critically ill patients, and the unmet need is really how can we deliver the medications we need, such as vasopressors, which a large proportion of our patients need, while giving them the least number of complications possible. And I don't think we've figured that out yet, because when we place central lines routinely, what we've found in our study, which we'll talk about, is that we are exposing patients to a 3% risk of major complications. And I'd like to think that with a lot of the newer techniques and newer options we have, that we can reduce that percentage. Yeah, so we did. We wanted to give people a concrete percentage of, when I put a central line in, what is my risk of complications. And so we did a systematic review. Initially, it started as 2015 to 2020 to get contemporary complication rates, and then we updated to 2023. So it was a systematic review and then a Bayesian network meta-analysis to determine the overall rate of complications from central lines. I think there are a few very important findings from the study. First, we were especially interested in major complications. So arterial cannulation, pneumothorax, deep venous thrombosis, and central line associated bloodstream infection. Those are the things that really, require major intervention or can prolong ICU stay, or can sometimes even result in death. And so the first finding was that when we pooled the rates of complications from those studies and ran Markov simulations to determine, if we placed a central line for somebody for just 3 days, what would be their rate of major complications, we found that it was 30.2 out of 1,000 catheters, or about 3%. The second major finding was that ultrasound guidance for placement reduced the rate of major complications substantially, for especially for immediate insertion complications like pneumothorax and arterial cannulation. I think when I started practice, I remember, actually I was a first-year resident, the first time I ever had to, place a central line in the community as a bedside clinician. And I was very nervous, and appropriately so, because there's so many things that can go wrong with these lines. And so I struggled a bit. And then, luckily there was an attending physician from another service who was there, and he tried to help. And fortunately, we got air in the syringe. We knew that there was a high risk of pneumothorax, and sure enough, the next day, that patient developed a giant pneumothorax, and the chief resident called me and said, like, I saw your patient had a pneumothorax, and but the reality is, you put enough of these central lines in, and you're going to get complications. And that patient just needed it for vasopressors, and at that time, 8 years ago, it was sort of the norm that anybody who needed vasopressors just got a central line, and you were just going to accept that many of them ended up having these complications. Whereas now, I think things have shifted in many ways. First, many centers, including ours at St. Michael's Hospital, you can now give vasopressors through peripheral IVs for, we say up to 72 hours. Other centers have longer periods, and, up to a certain dose, we say 0.3 micrograms per kilo per minute of norepinephrine. And so now, from the other research we've done, we've shown that about 50% of patients with septic shock and other forms of shock can just avoid a central line altogether and have their vasopressor delivered peripherally. But also, I'm very encouraged by newer techniques like midlines, which have been increasing in popularity, which some centers in the US, I know, have just switched from central lines to almost exclusively midlines, and when even for vasopressin and other drugs. And so, I think what the implication for me is that a lot of times we can avoid traditional central lines. We can reduce the complication rates by becoming familiar with ultrasound and using it. And when alternative things like midlines, which will we have another study ongoing to determine the complication rates of those, but it looks from other research like they're probably lower than for central lines. And so, when we can use alternatives to central lines, I think it's very beneficial for our patients. The risk of extravasation is extremely low, and almost all of those cases can be managed conservatively with things like phentolamine, and without any sort of tissue injury or tissue necrosis. And so I think minimizing the use of central lines when we can and when clinically appropriate is going to be very beneficial for our patients. I'm really looking forward to a few sort of avenues of research. The first is that the systematic review we did, there's also a component on peripheralized IVs and a component on PICCs and midlines. And I'm really curious to see what that, 3 days of sort of line use with those, what the rates of major complications are going to be and how they're going to compare to central venous catheters. And I suspect for midlines, it will probably be substantially lower, and something that may convince hospitals. We currently don't use them, but may convince us and others to start using them. And I'd also like to see more clinical studies and where we compare different vascular access strategies. There are some that have been published with large numbers, but they're mostly retrospective, and I think these findings ideally would be validated in prospective studies.